Thank you so much for coming. This is a very special program. We did one with this topic about 6 months ago, and this one is going to be very different. And we have some of my esteemed colleagues over here, and even more importantly, we have some past donors. Anyways, this is a part of our UKEEP program, Kidney Education. The first one we did was in March. And I know a lot of you have attended these programs. We did on PKD, hypertension, diabetes, nutrition, and this one is on living kidney donation. And we'll be going over that in a lot more detail. As you can see, my name is Anjay Rastogi, and just a couple of key points. Once again, thank you. I know this is a difficult time to come, especially this time of the year, but thank you so much for attending. Your feedback is very important, so we take the feedback and look at every single thing that you write. So things that you liked, things that you didn't like, and things that you think should be added in the future. So please give us feedback on that. Your contact information is very important. So we do have a mailing list. So if you don't have your contact information, it's going to be difficult to contact you. So please do provide your contact information. Now for questions, this is being recorded as you probably can see. So if there are any questions, you will have index cards. Do you guys have index cards with you? So if you have index card, just please write the question on the index card and just raise your hand and somebody will come and pick it up. And I will make sure that that question does get answered hopefully today, but if not, we'll get back to you. There are some booths outside, you probably see them, and they have research, education, and all the good stuff that we do. Now, this is our email address. It's called bruinbeans@mednet. This email comes straight to my office, and I always, the Bruin beans are kidneys, right? And Bruin is UCLA. So we were lucky to get this email, bruinbeans@mednet, so it's easy to remember. So the agenda for today, we have it in two parts. The first part, we'll be discussing living kidney donation. That's our topic. And we have broken down this into two parts. The first part, I'll have my medical colleagues, surgeons, and physicians discuss transplant in general, living kidney donation. And it's a very expert panel that we have today. And then the second half, that's going to be from 2:30 to 3:30 onwards, is going to be our past donors. So people who have given their kidneys, and they will be good people to ask questions. And I know there are people who actually might be giving kidneys soon, right? So, but this will be our second half, the past kidney donors. So first, I would like to invite our expert panel, the participants. First is Dr. Gritch. So if you can come here, Dr. Gritch. So Dr. Gritch is an amazing surgeon and colleague and teacher. And I've learned so much from Dr. Gritch. And he was so excited about this event. A person who's truly dedicated to helping people. And thank you so much, Dr. Gritch, for taking time on a Sunday and helping. Dr. Gritch is a surgical director for the transplant program. And he actually will be doing a major presentation and will be asking questions. Our second is Dr. Novak. So Dr. Novak, if you can come. So Dr. Novak is a transplant nephrologist, and she is heavily involved with the Living Kidney Donor Program. And also her expertise is PKD, polycystic kidney disease, hypertension, and diabetes. So we do a lot of clinical research together. Our next one is Dr. Kamgar. And Dr. Kamgar is actually on call. So we're covering his pager. So if he gets an emergency page, he might have to leave. But Dr. Kamgar is a transplant nephrologist, and a very, very good one as well. And we have our surgical fellow, Dr. Cohen, who does more than the surgery. An outstanding fellow. And one of the things that I've noticed when we go outside UCLA, when we look at our surgical colleagues, how much medicine they know. And I think it comes from the top, is Dr. Gritch. And when we have these meetings and discussions, how much medicine Dr. Gritch asks us, or actually has his own insight. So it's not that surgical, because a lot of times when we think of surgeons, they do the procedure and then they leave it up to the physicians to do, but not here. The surgeons are as involved as the physicians in the medical aspect, obviously the surgical aspect. And then finally, I will be moderating the program. So with that said, and then our past donors, and this is just, I think, alphabetical. Brandy is here. She'll be coming in the second half. Yep. We have Dawn, who's sitting in the front. Yes. And we have Miss Henderson, who actually drove all the way from Salinas to attend this program. So thank you so much, Miss Henderson, and her husband. And Christina will be our office manager, will be here as well. I don't know where she is. So she'll be going this. And then finally, Belinda will be joining the panel as well. So Belinda, so we, she's one of our past donors as well. So she'll be in the panel. So with that, I'll ask Dr. Gritch to come forward, and this is, he'll be going over this presentation. We'll be asking him questions as we go along. Dr. Gritch, if you want this. And do you want to just use this microphone?
Yeah. Can you all hear me? All right, good. Well, it is nice to be here. As you know, this is something we're very passionate about. The reason we're so passionate about it is twofold. One is that kidney disease is becoming more and more common, and many, many patients suffer with the consequences of it. And second of all, we're very fortunate to work with those people that are willing to, give of themselves to come to a solution for this. So we feel blessed to be able to work with you, and I think all together we've made a lot of success and hopefully more to come. A lot of this started only 50 years ago. These are twins. And on the right-hand side is Ronald and his brother Richard. And one of them had kidney failure and the other did not. And they were able to show that they were actually identical twins. And he then donated a kidney. And this is the very unique situation where the immune systems are actually the same. And so there's no risk of an immune reaction. And so they really sent a signal around the world that it is possible for one person to live on somebody else's kidney. And it took quite a bit of effort for this to happen, but it really has opened up the doors for tremendous success around the world. And you can see back in the 60s on the blue line here, the 1-year chance that the kidney would survive was pretty dismal. Only half of them actually worked. As they started to take friends and other relatives as donors, the immune response became stronger and stronger. And so scientists around the world came up with newer medications to try and block this immune reaction. And really the invention or the discovery of the so-called calcineurin inhibitors, cyclosporin was the first one, really changed the field, where you can see there's a big boost from 65% survival to 85% survival in just a couple of years when that drug came out. And despite this, we're continuing to get better and better outcomes for our patients that get kidney transplants, and there's less and less rejection, as can be seen in this yellow line. But there's a problem. Anytime we have patients that need kidneys, we have to have a donor. And the question is, well, who deserves to get a kidney? Basically, there's two ways of getting a kidney. One is to get a kidney from someone that's passed away, and the other is to get a kidney from someone that's healthy and living and can hopefully live a normal life with one kidney. For the deceased donor allocation, this has been a struggle because on the one hand, we want to have the best utility. We want the best outcomes. If somebody is going, or their family is going to donate the kidneys of a loved one that's passed away, we don't want that to go to waste. We want it to really help as many people as possible. On the other hand, there has to be some fairness. If you only use matching as an example, and you say, well, we're only going to give the kidneys to those that have a really good match, there's going to be inequality because the donors aren't always the same as the recipients. Because many of the people, for instance, those that have polycystic kidney disease, many of their family members can't donate. So, it has to be fair to everybody that participates in this system as well. And finally, we have to be somewhat efficient. We can't, find the perfect pair if one is in Chicago and the other is in New York. And so there has to be some balance, and that's where there's a balance between local and national priorities. So we have a fairly complicated system that I'm not going to go into for allocation of deceased donor organs. But the bottom line is this, that more and more people are in need of kidney transplants. And you can see that there's now more than 120,000 people that are waiting for kidney transplants in the United States. And there's more than 2,000 people at UCLA alone that are waiting for a kidney transplant. And you can see that more of the deceased donor organs are being used than living donor, but we are continuing to increase the number of kidneys from living donors. This also just kind of puts into perspective how many people need a kidney transplant as opposed to a liver transplant or a heart transplant or a lung transplant. We're very happy to say that at UCLA, the heart and the lung programs have done exceptionally well. Our liver program is also doing well, but the kidney program is really continuing to grow and expand, and I'll show you our numbers in a bit. But we have obviously the biggest need. There are, thousands of people that need kidney transplants, and the alternative is dialysis. But in general, it's recognized that people that get a kidney transplant have not only a better quality of life, but they also have a better survival. So, Dr. Rastogi wanted to...
So that's a question. So we have questions in the slide deck. So when can you be referred to a transplant program? That's a question for the audience. What is it based on?
If you're declared ESRD.
I'm sorry?
If you're declared ESRD.
Okay, so they have to have ESRD. What else? GFR, very good. And what GFR? Yes, but what number do we look for?
Oh, if it's 15 or under.
Right, 20. Right. So if you go so this is an important number. So and I've gone over this, and you're absolutely right. So we go by GFR, and if your GFR is 20 or below, you can be referred to a transplant program. But if I'm correct, they won't assess you if it's above 20, right?
Well, I think what's important is when your kidneys are failing that you see a nephrologist, Don't wait until you're 20 to start paying attention to your kidney function. Right. These guys can help you well before then. However, it wouldn't be fair to give somebody that really is not even that sick a kidney transplant when there are other people that have been on dialysis for 10 years, right? So we realize that there are certain advantages to getting people transplanted early, and that's why we start to evaluate people when their kidney function is less than 20 or roughly 20% of normal. And that is a national policy, but I want to say that you should start to think about your plans for renal replacement therapy or maintaining your kidney function well before that.
Right. So I think that's an important point, and a lot of you are my patients over here as well. So the pre-dialysis care is very important, or pre-transplant care. So this is only when you can be seen by the transplant clinic. But obviously, way before this, your care should be there with your nephrologist. So I think that's a point. But 20 is the number. And the reason why I bring this up is a lot of times the patients are being referred late to the transplant. And in our clinic, as soon as they hit 20, is an automatic, they get referred. But you're absolutely right. They need to start thinking about what we call replacement therapy once it falls below 30. That's where we really start talking about the plans. Yes? That's okay, Mr. Anderson. That's fine.
On the creatinine,
Right.
the GFR on myself wasn't above 20.
Right.
But the creatinine was going up.
Right.
And I can see the doctors down here.
Yeah.
community said you need one subject
Right,
to kidney failure.
right.
I much about the GFR, but I do know.
Right. And Ms. Anderson, I think you bring up a very important point, and that's why we had these kidney programs in which we want the patients and their families to be proactive. We say that you're your best advocate, right? So knowing your numbers, we know your glucose numbers, we know your cholesterol numbers, but know your kidney function numbers as well. And these are all relative numbers. These are not absolute numbers, but at least they will give you some idea where you stand, right? And speak to your healthcare provider. But if you have these numbers, tell them what should be my next step. And if you don't get the right answer, then try to get the right answer. So you're absolutely right. There's a lot of lack of information for patients. Yep, very good. Now, what is a preemptive transplant, which is something kind of linked to the GFR? So one of the questions that we get asked is, do we have to be on dialysis to get a transplant? The answer is no. Once your GFR falls below 20, you can be considered for a transplant. But the waiting list is so long, and Dr. Gritch will be going over this in a lot more detail. If you don't have a living donor, the likelihood of you getting a preemptive transplant, that means a transplant before you get on dialysis, is pretty low. So that's what a preemptive transplant is. Very good. Now, the other question that we get asked is, so we went over deceased donors versus living donors, right? And the question is, are there any advantages of having a living donor than rather waiting for a deceased donor? And we'll be going over that in a lot more detail in the next few slides.
So, first of all, it's pretty obvious that with a deceased donor, nobody has to go through an operation to get the kidney, right? So with a living donor, we're taking someone that is very healthy, that doesn't need an operation, and putting them through an operation. So that's a disadvantage. On the other hand, why would you do that? Well, this slide shows the differences between somebody getting a deceased donor kidney, and we're looking at 3 years after transplant, how well does that kidney still work? And is it functioning? The first thing that comes to mind is that these lines are not all at the top at 100%. Whether you get a kidney from a living donor or whether you get a kidney from someone that's passed away, there is always that small risk that the kidney will fail. And I've shown you that we're doing much better these days than we did in the past, but it does require a lot of special attention to taking medications and the care. But despite that, there is a big difference between getting a living donor kidney, whether it comes from someone that is in the family, like an identical brother or sister, whether it's from a spouse, or whether it's from a parent. A parent has half of the genes are passed on to their children. So if you get a kidney from your child, or from you give a parent and you give a kidney to a child, half of the genes will be the same. So that always has some advantage. But any difference between the donor and the recipient is enough to trigger a rejection, and hence the need for immune suppressing drugs. So this is what we call matching, and it does play a role, but a more important role is the difference between having a transplant and not having a transplant. There's a huge difference in terms of the quality of life and survival. There's a relatively smaller difference between those that have a kidney that is either from a living donor or a deceased donor, or someone that is a well-matched kidney versus not so well-matched. So we take into account all of these, but it's very clear that having a living donor kidney on average has better graft and patient survival than if you get a kidney from someone that's passed away. And you can see that the trend continues to improve for both of them, but it's still, the lines are not really coming together. A living donor is a big advantage for the person that's getting the kidney.
Just some key points over here. Transplant is so when we talk about replacement therapy, what Dr. Gritch had alluded to, when your GFR falls below 30, there's dialysis and there's transplant. And in majority of cases, transplant is the better replacement therapy than dialysis. I think that's really a key point. And even if you look at the numbers, living donors, a transplantation has advantages over deceased donor. So I think that's a generalization we can make. So the next question is, who can be a living donor, right? And we'll be going over that, how we do the assessment.
So first of all, it starts with the education, and that's in part why we're here today. We have a very formal process at UCLA where you come to a lecture that our coordinators and nurses put on, and they go over this in much greater detail. But first of all, we want people to understand there are risks and there are benefits to being a living donor. We want people to donate of their own will, and there should be no coercion, or people should not be forced into donating a kidney. And then we do have to go through some of the medical risks, and that involves a very careful history and a physical exam, review of the medications, and that's what our nephrology colleagues do. We obviously, the transplant surgeons and the doctors that are taking care of people that need a kidney have an incentive to find a kidney for that patient, right? So we have actually separated the group of doctors that evaluate those people that are interested in donating from those people that are putting in the kidneys and trying to get the best results possible, because we don't want to push somebody or trick them into donating. And so that's why we have two separate teams. And, their job is to evaluate what is the risk of donating a kidney. And it's not up to any of us to say you can or cannot donate, but it's up to us to make sure you have enough information to make that challenging decision. So how many people in the room think it's a miracle that someone can donate a kidney to another person? Truth be told, it's not. But that doesn't mean that it's any less miraculous that it can be done and that people do it. To some extent, the transplant community has developed this myth that only an identical twin or someone that is exactly like the person that needs the kidney can donate a kidney. And the truth is that as long as the person that needs the kidney doesn't have a strong immune reaction to the donor, that's all we have to accomplish in order for that kidney to function for many, many years. And by avoiding certain combinations and with the use of the immune suppressing drugs that we have today, many people can get a kidney with no match at all. All right? And the outcomes are actually very good. So in order for us to evaluate a donor for a particular individual, the first thing that we have to check is the blood type. Because if you are, for instance, blood type O, that is the universal that is the universal donor. They can donate to any blood type. But if your blood type is AB, you're the universal recipient. You can get a kidney from any blood type. And the reason for that is that you don't make antibodies against yourself. So if you have blood type AB, you do not make antibodies to A. And if you are AB, you also don't make antibodies to B. And it turns out that most of the blood types are broken up into those categories, A, B, O, and AB. What's a little bit interesting is if I'm O, why do I have antibodies to A? Well, it turns out that when you're born, you don't. But after you start to eat foods and you're exposed to various pathogens in your intestinal tract, as a defense mechanism, you start to develop antibodies against these foreign proteins. And that's true for many things, viruses, carbohydrates on bacteria. As we get older, we are exposed to more and more things, and we have more and more antibodies. For instance, a pregnancy is a rather miraculous thing because the child inside of the mother is genetically different. Half of the genes come from the father. And so at some points in a pregnancy, though, the mother's immune system is exposed to some of these foreign proteins, and she may develop antibodies. The same is true for the Rh factor, the plus minus that we talk about, A positive, B negative blood. So when we are evaluating a donor, we have to look to see whether the blood type is compatible and whether or not the patient has antibodies. It doesn't matter if the donor has antibodies because we're going to just give the kidney. We're not giving a blood transfusion. So that's where we start. But this used to be much more important when we didn't have any options for getting past these barriers. But there are now ways of doing kidney transplants across blood group barriers and against some of these antibodies if we give more immunosuppression and we get rid of the antibodies. But I'm not going to go into a lot of detail on this because it is more complicated, but we have another solution to that that I'll go over in a minute. But the bottom line is that if anybody is interested in donating a kidney, we have someone that will benefit from that and some way of making sure that the one that they want to donate to will get a kidney, as long as we have someone in our pool of people that need kidneys that is able to donate. So the top couple of lines are no longer as important as they once were because of this thing called the kidney exchange program. We also can, as I said, remove these antibodies. That's what we call desensitization. But before we do all that, we have to look at the basic blood tests, x-rays, and other things, and the nephrologist review all this to make sure that it's healthy enough to donate a kidney. We also then do some x-rays to look to see if the patient does have two kidneys, to see how complicated it will be to do the transplant. And then finally, we do something called a cross-match test. So the person that is going to get the kidney, we check to see if they have an immune response against the cells of the donor. And if that's positive, that's a bad thing, that means there is a reaction, we then have to consider either getting rid of those antibodies or doing something else to make sure that we have a better outcome. But if the cross-match does not show a reaction, that's when we proceed with the kidney donation. So
how long does the whole process last? Any idea? Well, Alyssa just went through this. How long did your process last? A month? Yeah. So it depends. A couple of months, and we say 3 to 6 months, depending upon if there are issues. So this is all if everything is going well. And just to summarize, we do a full set of blood tests, urine tests, imaging studies that includes a CT scan, an X-ray. They're assessed by the surgeon. They're assessed by the nephrologist. They're assessed for psychosocial issues as well. So we do a full and thorough assessment, and normally the assessment is done over 2 days, and most of you probably have gone over that. And the reason why I try to cramp in 2 days is that it won't be spread out the whole week. And then we look at those results. Within a week, we should get most of the tests back. And if there's further things that need to be done, we address them. But one of the things and then if there's issues and they can be resolved, we ask them to be resolved or at least get tested more. If everything has been resolved, then you're clear to proceed. And it will take anywhere between about a few months. And I think one of the questions that we get asked is, why does it take a few months? So it takes a few months because there's OR time, there's also a waiting time to get reassessed. Sometimes we're booked a few months out. But one thing that we do is if there is a medical need that a patient is unstable on dialysis, then we will expedite it. Also, if you're getting close to dialysis and this transplant will help you avoid dialysis completely, then we try our best to expedite that as well. So what we call preemptive. But normally it takes a few months to get the whole workup cleared and proceed. The other thing that we discuss is it also gives the donors time to think about it, right? So, and one thing that before they call the number and call the transplant program, that they want to donate or they're interested in the workup, it's the whole process before that. Sometimes it takes months, sometimes it takes a year or even more than that to decide whether they want to donate or not. And a lot of people, our patients or donors, actually read about this before they come in. So I always tell our potential donors is, is think through it. Take your time, to think through it. A lot of them might have actually thought through it and it's done. If they have not thought through it, this will give them time to think through it as well. And in our second half, we'll have the past donors, and you can ask them questions, what they went through, how long it took them, and also what did they think, and how long it took to convince themselves that this is the right thing to do and move forward. Very good. So hopefully that answers the question.
As I mentioned, we do fairly sophisticated x-rays and laboratory testing, and sometimes we find things that people weren't aware of. Most people have 2 kidneys, but not everyone. Most people have 1 artery and 1 vein going to each kidney, but you can see that in some cases it gets a little more complicated than that. That doesn't necessarily mean that that person cannot donate. Sometimes we find that they have a kidney stone they never knew of, or we find a little nodule in the lung, or we find some other abnormality on the blood test. And one of the things about the donor evaluation is it is a very, very thorough checkup. If you make it through that process, you can be pretty well assured that you don't have anything major going on. These are some of the things that sometimes will slow the process down because we don't want to rush into something and then say, geez, we made a mistake. This person really shouldn't have given up 1 kidney.
So this brings back to the questions, how do we protect the potential living donors? And Dr. Gritch went over this, a few slides back, in which at UCLA, and I think that's a requirement now, the recipient program is separate from the donor program.
That's a UNOS requirement.
UNOS requirement. So we separate the recipient from the donor. So that's the number one. So there's a donor team and there's a recipient team, because our job is to protect the donor. And as was mentioned, it's a very, very in-depth assessment that we do for donors, both medical, surgical, and psychosocial. So that's number one, the separation of the 2 programs. The number 2 is we actually have somebody called what we call ILDA, Independent Living Donor Advocate. And for our program here, it's a social worker. So they will do an independent assessment of the individual to make sure that psychosocially they are actually okay. And then there's a full committee that meets, and we meet every Friday, and that includes our surgical colleagues, our nephrology colleagues, the radiologist, the social worker, the coordinators. It includes a whole team, and everybody has a say. So if somebody is concerned that they should not proceed, then we will address that. So there are multiple checks and balances that we have to make sure that the donor is protected. And then the other thing that and a lot of you have actually gone through that even if they have decided to proceed and they're cleared, they have a right to say no till obviously till the kidney's out, right? Then I think it's a bit too late.
Yeah.
Has it ever happened that they put the kidney back in? No.
No, we never do that because it would be another operation and it would probably be more risky than beneficial.
Right.
So, in ethics, there's always a balance between paternalism, in other words, I know what's right for you and I'm the government and I'm going to tell you what to do, versus, no, I know what's best for me. I'm going to do it my way. That's how I am. So there's never a right and a wrong answer there. We feel that we have a certain obligation and a responsibility to not allow someone to do something that is foolish. But at the same time, people have brought up questions like, well, how old is too old or too young to donate a kidney? So, these are things that we have a little bit of a judgment call in every single case. And that's why we have a whole committee. But just so we know, our policy is that if someone is less than 25 years old and they want to donate a kidney, we feel that that's a really big decision to make at that age. There have been exceptions if, they are very mature and they understand. But this is why we have a whole committee, because we feel this is a very complex decision to make, and you do need to have some life experience before you're ready to make it. So these are some of the things that we find in patients that did not suspect. They thought they were perfectly healthy and they wanted to donate a kidney. Sometimes we find that they have blood pressure that's not well controlled, or maybe their blood sugar is a little higher than they thought it should be. Sometimes they're a lot heavier than they thought they were. We are finding something called fatty liver disease or a metabolic syndrome in a large percentage of Americans. And we don't always know what that means, but we do know that there are some risks associated with that. We sometimes find cancers that are at a very small stage, but yet could perhaps be passed on to the person that's getting the kidney or cause a problem later on. We find that roughly 1 out of 3, the blood type is not compatible. And about 1 out of 5, they may not have much of a support network. You know, if everything goes perfect, okay, that's great. If they can go right back to work, if their marriage is fine, and if everything else is fine, then they'll be just fine. But you always got to ask yourself, what if? What if the operation doesn't go perfect? What if they have a little complication? Is that going to set them back for life? So of all the people that come to UCLA and say, I want to donate a kidney, roughly 20% are being advised to go ahead with that. I find that number somewhat comforting because I think we're being very cautious. On the other hand, a lot of the recipients are saying, you guys are being overprotective, you know? They'll be just fine with 1 kidney. Or sometimes it's a spouse or something like that. They say, well, I'll be fine. I got a little blood pressure. That's okay. It doesn't hurt me. I'm doing fine. I want to do it, you know? So we don't have hard set rules. And to be honest, these rules are, you know, changing over time. But we are doing an operation. And as the surgeon that's going to stab you with a knife and poke you with needles, you know, I have a certain responsibility to get you through that. And it's scary. I gotta be honest. It's a little scary when you operate on someone because the only thing I can do if you're a donor is make you worse than you were before. I'm not gonna make you any better. Whereas if you're a transplant patient, you know, you were bad off to begin with, and all right, now you're still bad off, but I didn't make you any worse than you were. So when you're doing a transplant, the chances are, you know, you're gonna be a lot better. When you're a donor, there's a chance that you're probably going to be just fine, but a small percentage of people are a little bit worse off. So it's a very, very big responsibility, and we take it very seriously. The way we usually do it is we make 3 small incisions, and we do what's called laparoscopic removal. We fill the abdomen with gas, and then we remove the kidney through a small incision, kind of like a C-section. Around the country, about half of the people have their kidney removed through an incision around the belly button, and they put in a couple of other trocars. So this is the way it's done pretty much around the United States. Prior to the year 2000, we were doing open nephrectomy, and we would have to cut through the muscles in the side, and that operation took about a month longer to recover from. With this kind of surgery, people recover fairly quickly. I'm going to let the donors explain how long it takes to recover because I haven't had the operation and they have. But we can go into that in greater detail if there are questions later.
All right, so that's the next question. And these are all questions that have been asked when we do the donor evaluations. So what are the potential complications from kidney donation? And these are both short-term and long-term. The short-term complications are surgical, mostly, and the long-term are medical. So we'll have, I think Dr. Novak can answer this question about the long-term complications that can happen with kidney donation.
Can you hear me?
Yeah.
Okay. Based on very high-power study that came out in 2009 among about 3,700 of donors nationally, they found that the quality of life score among donors, interestingly, are higher than normal population. About medical conditions, they found that they have the same survival rate. That was very important finding. Donors are at small risk of high blood pressure if donation times is passing 10, 12, 15 years. Mm-hmm. But if you see even normal population, even 1 out of 4 with aging will have high blood pressure. So what we do recommend, medical monitoring. The first few years will be like 6 months, 12 months, and 24-month follow-up either with us in donor clinic or your primary care physician. Office for blood test, urine test, and blood pressure check. And after that, I think normal checkup with the primary care
Primary care
physician
should
would be
be enough.
sufficient.
Right. Very good. Dr. Kamgar, do you want to add anything? Thanks, Dr. Nobat.
The main concern, I think, when you donate is if I'm gonna need dialysis.
Right.
So there is a small increased risk of donor needing dialysis. We do all this evaluation to make sure that risk is minimal, and they don't end up needing being on severe kidney disease. So I think one of the complications that is always concern is the kidney function after.
Very good. Dr. Chris, do you want to add?
Dr. Cohen, you want to? I should answer. My fellow is Dr. Cohen. He's going to be moving to Seattle in about 6
You're
months.
leaving
and,
us?
But he has been taking nephrology call, so he's very well knowledgeable in the medical and surgical aspects of taking care of patients with kidney failure. Can you tell us what some of the complications are from the surgical side of donating a kidney?
Yeah, so from the surgical side of things, infection is really the most common complication that donors experience, and that's two reasons. One is because we make an incision through your skin, a very important barrier to infections. So cellulitis or wound infection that happens in maybe 1 to 2% of patients, and the other one is we put a catheter in your bladder while you're asleep because you're asleep for 3 hours or so, and as you're waking up in the recovery, you obviously can't pee. So we have the catheter in there. Anytime we put any sort of foreign body inside your bladder, then there's a risk of infection there. So urinary tract infections, and that's probably the most common complication we see. Maybe 3 to 5% of donors experience urinary tract infections. As we move beyond those complications, they become kind of increasingly scary sounding, but fortunately much more rare. So there's intestines that live near the kidney, the liver lives near the right kidney, the spleen on the left, nerves that run next to the kidneys, and those things can get injured. Fortunately, those complications are rare. And then there's always a chance during the operation that if there's bleeding or a need to really protect the patient's safety, that you have to convert to an open procedure. So rather than have those 3 small incisions, we have to go back to the old incision that used to be made prior to 2000 to make sure that the donor makes it through the operation safely. But again, fortunately, that's quite rare.
Very good. So I think the surgical expertise is also very important with the surgical experience and stuff. So that's. Now, just for the complications from medical standpoint, so we discussed survival. So studies are ongoing, and we'll keep on learning more and more. One of the things that we have seen a change is that maybe 20 years ago, the patients who were being accepted, the criteria was much more stricter. We are getting a bit more liberal. We have seen that in our own practice, right? Patients that we probably would not have accepted before, even with hypertension, we are now accepting them. So there's always a risk, like Dr. Gritch and my team said, there's always a risk. The consider is that risk worth taking, right? And this is where the committee comes in, and we need to decide whether we can put our donors at that risk. After that, if we decide that that's an acceptable risk from our standpoint, we discuss with the patient as well, right? Because it's difficult for us we don't have a crystal ball. Say, well, you know what, this is what's going to happen. If we had that, things would be so much more clear. But then we can just make an assessment. And those are the risks that we discuss with the potential donor. Look, this might happen. Dr. Kamgar mentioned there is a small risk of these patients ending up on dialysis themselves, ESRD. It's a very small risk, but can happen. So those things will be discussed. But once again, I think the screening process is very critical. And that's why we go through a very thorough screening process. But it's not perfect. But one thing I can assure you, based on what we know so far, it's a relatively safe procedure. And if we are clearing you, then there is a pretty good chance that everything should be okay. But once again, things might change. Patients might get diabetic after they transplant. They might develop cancer after they transplant. So those things we can't predict. So I think that's something important to keep in mind.
Something I just want to add is, if a donor requires dialysis or requires transplant, the advantage they get is they go on top of the list, so they don't have to wait on the list.
So that's one more thing that we do for donors is that if they need transplant, they go go on the top of the list. Yeah.
But it would always be better for them to have a living donor, as would any other person. So,
Right.
you know, it's, but we do have some safety net, if you will, built into the system, because we feel that these people need the, you know, the best attention that we can give them.
Now, this is probably Dr. Cohen can help us with it. And this is basically how soon, and this is a question that we get asked often is what happens after the surgical process. So I know there are a lot of past donors here, so we'll be discussing with them as well. But Dr. Cohen, what advice do you give post-surgical?
Yeah, well, I think it's important to know what the person does for work because if it's relatively, not strenuous at a desk, on a computer, that sort of thing, that's going to be a different return to work timeline than if someone who has to, move heavy boxes, something like that. So that's one of the most important things I think is when we're assessing, and talking with patients about their recovery is, well, what do you do for work? You taking care of a bunch of children, like that's going to require, you to be near 100% before you jump back into, childcare or preschool, something like that. That's kind of what I like to focus on, and we can let the donors here specifically say what their experiences were, but it's quite a range, honestly, that I've seen. People that are just like, I need to get back in the office right away, and they like a week after surgery, they're like, can I please go back to the office? And well, I don't see any reason you can't sit at a desk and type on a computer if you'd like. And other patients, again, I've seen that, teachers, again, people that are working with children or moving lots of heavy objects, I think you really need to make sure you're fully recovered there, and that can take a period of time.
Very good. And by the way, roughly about 2 weeks, you say they can.
Yeah,
go
again,
back?
for the most demanding jobs, I really think a full 6 to 8 weeks
Right.
is what I would recommend. You want to basically feel like you haven't had surgery before you jump into a really demanding job again. That would be my opinion.
And also what medications, pain, right? That might also affect if they have a lot of
Yeah,
pain.
so after any operation, we give you narcotic pain medications, and then you can transition those to things like Tylenol after days to weeks. But certainly, if you're operating machinery, things like that, you don't want to be doing that when you're on narcotic pain medication. So you want to be off of that. And then again, those narcotic pain medications have side effects. Constipation is a major complaint that we hear about, and so then we have you on a bowel regimen as well, stool softeners, things like that. So those things can take time to normalize and affect people's daily routines in variable ways depending on what they do. So
Very good. And then thank you so much, Dr. Cohen. And then we'll speak to our past donors, what their experience has been getting back to work. Very good. Thank you. So what follow-up is recommended post-donation? And so there's what we do as for medicine, and then we have surgical follow-up. So I'll start with, if Dr. Cohen wants to answer that what do you tell them?
yeah. So anyone that donates a kidney, we see you back in our transplant clinic. One of the surgeons sees you. And the point of that visit is to make sure, again, your bowels are recovering, your pain is well controlled, and that all the incisions are healing up nicely, and to address any concerns that you have. So we typically see you back around 10 to 14 days after your surgery. And at that point, a large majority of patients are headed on a great course. Their incisions look good. They say their bowel function's getting back to normal. They're eating and drinking well, and then they're starting to kind of pick up on their activity. So at that point, if you're looking really good and you're feeling good, then that's the kind of last surgical appointment that we schedule. Of course, we're happy to see any donor that has any questions at any point if they want to come back. Again, we're always available on the phone, email, those sorts of things. But again, around 10 to 14 days, we check in on patients and make sure everything's heading in the right direction.
Very good. And then as far as from our standpoint, Dr. Novak went over, so we normally don't require you to come and see us as nephrologists after donation. If you want, we are always, like you said, we would love to see you, but you're not required. What we do require, as was mentioned by Dr. Novak, is at 6 months, 12 months, and 24 months, we need to get you a blood test, urine test, and also we like a blood pressure check. These are simple tests, can be done anywhere. We just need to get the report just to make sure that everything is okay. Also, if everything is stable, then you should have your normal follow-up with your primary care physician, whatever routinely. When we go over our assessment, we strongly recommend that you have a primary care physician or at least access to healthcare provider and get a simple blood test and urine test and a blood pressure check. That's all that's needed. So nothing too strenuous. And if something comes up, we're always available to help you out as much as we can. Very good.
So, what are some of the trends in living kidney donation? You can see that in the past, it was mostly related donors, that is, parents or siblings. In roughly like 10 or 15 years ago, we started to do more and more spousal donation. Now, in that sense, there isn't usually the matching that we had talked about that you inherit, but we found that the outcomes were still very good. As that trend started to show that we had very good outcomes, we then started to increase the number of people that were friends and family and so-called unrelated, and in some cases even complete strangers have been able to donate. And this trend is slowly increasing over time.
So Dr. Rich, the donors that we have, past donors, 2 of them were to spouses, 1 to a son, and 1 was what we call non-directed. So you'll get a full spectrum of donors. So we'll be going over that in a lot more detail.
This also just shows you roughly the ages of the people that are donating. And you can see there it shows the very bottom, we generally do not take anybody that's less than 18. Those that are 65 to 70 is slowly increasing. Typically, an older donor will donate to an older recipient. If we have a very young patient, we generally want to find a kidney from a younger donor. But that's not always the only thing that is important in terms of the long-term outcomes. Males and females, there's a slight distinction there, more females donating than males. You can see that the ethnicities really are across the board. And we talked briefly about that matching already.
Right. So just for the age, Dr. Gritch, I wouldn't go, so we definitely don't take anybody younger than 18. That's a hard cutoff. 18 to 25, it has to go to our committee. We have to approve that. We definitely don't want to take younger. And there are a lot of reasons for that. One is, do they understand the process? We discussed that. But also, it's young. A lot of these metabolic changes happen in your 30s and 40s. So we want to make sure that we feel much better if it's in that age group. And then above 65, the surgical risks go a bit higher, right? That's as opposed to just medical risks.
True.
Yeah. So above 65. And what's the maximum we've done? I think 75? We did an assessment for 75.
Yeah.
But we've done in the early 70s. That's the maximum age we have done. But once again, it's the risk to the donor that we're concerned about. So that age factor is important. Now, how do you match a kidney? And I think this is important because we do get a lot of questions is how much is my kidney match? Do I have 2 out of 6 matches or 1 out of 6 matches or 6 out of 6 matches? And I'll rather take a 6 out of 6 rather than a 5 out of 6, right? And I think what Dr. Gritch showed the slide initially about the immunosuppressions, that was probably a bit more important, maybe 30, 40 years ago. But with now the new medications, it still is probably a bit important. Some of the matches are more important than others, right? But it's exact, significant depends upon case by case. So speak to your transplant nephrologist and surgeon and what the significance of that match exactly is. And I think, as was pointed out, getting a kidney is probably more important than looking for those exact matches that you have. And when we talk about matches, we look at what we call HLA matches. We look at also blood groups, right? And a lot of there is still about a misconception that if your blood group incompatible, you don't have the same blood groups, you can't donate, and that's not the case anymore. We have paired exchanges, and we also have the ABO incompatible group. So just something to keep in mind as well.
A lot of times people ask about these other alternatives to, a living donor. So, A, we are trying to find more and more people that are living donors because we know that the outcomes are better. But people have said, well, we should use more and more of the kidneys from people that have passed away. And many of the kidneys, unfortunately, are not used and are thrown in the trash. And maybe we should be using more and more of these kidneys. But because the outcomes are not as good with deceased donors, and you really don't want to put somebody through an operation and then not have a kidney that's working, that's a tough decision that we have to make. Finally, people said, well, why can't we use animals from organs from animals? Or when are you going to be able to grow a kidney in a dish, And unfortunately, the technology on that, although it's very exciting, is just not ready for use at this time. It is exciting, particularly on the xenograft frontier. It may be within the next 20 years that we can solve some of these problems. But today, it's really something on the horizon, and it's really not going to help any of you or your family or friends. So finally, we talked a little bit, what do you do if there isn't a match? And this was the very first kind of a simple exchange. I talked about the blood groups, the A and the B and the B and the A. Well, a very simple exchange was if I'm blood type A and I have a B donor and somebody else is the exact opposite, well, why don't we just switch? And that works perfectly well. The one challenge to that is that there are a lot more A's than B's. So you can only find a few of these within a certain group of people, unless you get bigger and bigger groups. But it's still never really a solution to the problem because there's many more A people than B patients. So we decided to make it a little more complicated. So we would do three-way exchange. One of the challenges with this, though, is that now you need 6 operating rooms all at the same time. You need 6 surgeons, you need 6 anesthesiologists, and the hospital's like, well, we're not doing all that because we can't cancel everybody's operations just so you guys can do your little thing. And not to mention the fact that if one of the 6 persons gets sick or has the flu, the whole thing falls apart, and then we got to reschedule the whole thing again. So although this has been done, and you may have read about it in the papers, it's really becoming overly complicated. The reason that it all had to be done at the same time is if I'm an A and my wife is B, and then I donate my kidney to the A person, and then the other guy gets sick and doesn't donate a kidney to my wife, well, I'm screwed, right? Because now my wife didn't get a kidney and I already donated. So we did these things all at the same time. A huge innovation was this exchange program, or what's called the non-directed donor chain. So if there is somebody that is willing to donate a kidney without needing to get anything in return, that's a big ask. But there are some of these people. And rather than just give their kidney to somebody that's on the waiting list, a couple of people said, you know what would really work well is if we gave that kidney to one of the people that has a donor. So if this person gives to this person, then that donor will give to the next one. And this creates a chain reaction. So one person donating can actually unleash or coordinate, many transplants. If we collaborate with other programs around the country, we're now shipping kidneys from New York to Los Angeles and to Chicago and to Florida and to San Francisco. You can see that there was one of these exchanges that involved 60 people. So this is, in a sense, what we see as the future. And it's already here today. More and more of our living donors are going through this kidney exchange program. It started out as being only necessary for those where they didn't have a match. But one of the things is, for instance, I mentioned about an O donor being a universal donor. So let's say you have a husband and a wife, and the husband's going to donate to the wife, and he's blood type O and she's blood type B. Well, if we went through the exchange, that husband could actually help 2 people. He could donate a kidney to an O patient, and then somebody that has a B donor that couldn't give to the O will make the exchange, all right? So this kidney exchange program is actually increasing the total number of people that can donate by about 30%, because that's the number of people that have a donor, but their blood types are incompatible. And if we also throw into this mix people that have had pregnancies or people that have antibodies from a previous transplant, we're now even increasing the number of people that can benefit from a living donor and not have to wait for a deceased donor, and not have to go through these really heavy doses of immune suppressing drugs to remove the antibodies by swapping them away. So we've been quite excited about this kind of an innovation.
So, Dr. just one question that was asked, and this is open for the panel as well. Suppose somebody has a donor, right, that can directly donate to that. Is there any advantage of going to the exchange program?
It depends. Sometimes we can't do any better. Let's say there's a brother and a sister, and their blood types are compatible, and they are a really good match. We cannot do any better than that. That's just, we're going to get the best outcome, and we shouldn't mess with that. But I gave you the example of a husband and a wife where there's really not likely to be much of a match because they didn't inherit the same genes from their parents, right? Or there may be a situation where the recipient has a lot of these antibodies. And so if they have a donor, but they just cannot match to them. So the compatible pairs, if they enroll, they can actually increase the number of exchanges. The more people we have in the pool that are willing to swap, the greater is the chance that we can find a kidney for someone that's very hard to find a kidney for.
Very good, thank you.
So this is just a quick summary of the results at UCLA. And this shows two things. One is we do quite a few transplants, roughly 300 a year, and it's been gradually increasing. And you can also see that both for our pediatric patients and for our adults, that the number of living donor transplants has continued to be a significant part of our overall transplant. I'm happy to report that in this last year, we've broken the record for the number of living donors. It's now 137 or 8, I believe, and we haven't finished the year. The total number of patients that have been in the exchange program, UCLA is the #1 program in the United States right now. We have a group of nephrologists, immunologists, nurses, and coordinators that are all making these exchanges happen. And we have a lot of people in our community that support this effort. So it's an exciting time to be a kidney transplant surgeon.
Right. So these numbers, so so LD means living donor, adult, so 116, and that's peds, so that was in last year, but we have already crossed that number. So that's and we still have a few more weeks to go, so it's great.
So we talked a little bit about the changing landscape of who can be a donor, and we are now considering patients that are otherwise healthy, that may have very mild high blood pressure, people that are overweight. Obviously, these are risk factors for kidney failure going into the future. So it depends a little bit on the age and the combination of these things. If somebody was 25 and had these problems, we wouldn't consider it. If they're 65 and have these problems, you could say, well, maybe it's just par for the course. We're talking about some of the donors over age 70, very small kidney tumors. We find that these incidental tumors are noted. Oftentimes they're very benign. It's kind of like having a mole. And so if you're going to remove it, it's not going to hurt the person that's donating or the recipient. Kidney stones. And then we've talked about people that are donating without knowing who the recipient is. And some of these other, mild things that we're finding on the evaluation.
So I think the point that you also made before, now we're accepting more donors that we probably would not have accepted in the past. But age is a factor. So if it's a 35-year-old person coming with mild hypertension and obesity and high cholesterol, as opposed to a 65-year-old person, it's a bit different. So there are different factors that we take into when we decide who we clear and we don't clear.
And I think we have to emphasize that why we're changing is in part because of the pleas of the families that would benefit from a transplant, and also a careful review of the data. And finally, this discrepancy between the need for a transplant and the lack of a good alternative. So that's why we're softening a bit and trying to be a little bit less paternalistic, and we're trying to be more collaborative with our patients to come to the best decision for them.
And I think that's a very important point, because 6 or 7 years ago, we wouldn't accept anybody over 65. And the only one that we made exceptions was a spouse-to-spouse donation. I still remember that, right? We won't even, it was a hard cutoff, 65? No, but only time we made an exception, because the benefit that even if there was some adverse events down the line, age or ESRD, the benefit that a spouse will get from the other spouse living longer and healthier outweighed that risk. But now we are looking at, I mean, I always say, and we'll be discussing the living donors, this is a priceless gift that you can give to someone. And it definitely does change their life. So when we have a family member whose life gets affected, it affects the whole family.
So the latest twist on this is...
How many have seen the voucher program, by the way? So this is the voucher program that Dr. Gritch will be going over.
So, again, this is just an example of how we've been influenced by the patients. I have to emphasize, the patients are the pioneers here and not the doctors. They are the innovators. They are what driving us to do things that make us uncomfortable. And that starts back 50 years ago. So this is a young boy who does not have end-stage renal disease, but he has some kidney abnormalities. His grandfather is a judge, and he's 64 years old. And at that time, we said, well, the upper limit of donation is 65 years, and the clock was ticking. And he said, well, I'm actually very healthy. I feel good, feel fine right now. At some point, if my grandson needed a kidney, I'd be happy to give it to him. But we didn't think that he was going to need a kidney in the next 5 years. So he said, what if I give a kidney to the pool, and then later on, when he needs a kidney, he'll get one back? And we're like, what? And then we said, well, can we make this happen? So we're fortunate that he was very emphatic about it, that legally, this actually made sense. Second of all, we had to make clear that this is not UCLA that is going to owe a kidney to his grandson, but we had to have an infrastructure. And so the infrastructure was built with a nonprofit organization called the National Kidney Registry. And this nonprofit organization is involved in organizing all of these exchanges. So we did have some people that had donated out of sequence. I told you that, we wanted to have a situation where if you're going to donate, you make sure that your recipient's going to get a kidney. But sometimes it's just not, life gets in the way. So we had one young man who wanted to donate to his mother, but he was in the military. And it turned out that she then had an illness and he couldn't donate when he was on leave. And then he would have had to go back onto active duty, and then he would have to wait another couple of years before he was free from active duty. And then his mom would probably have to be on dialysis those times. And he said, listen, what if I just donate a kidney now, and then you give her a kidney from someone's a good match whenever she's healthy enough? We said, all right, we'll see if we can make that happen. And we did. And then we had a couple other examples like that. So generally, though, it was a relatively short period of time where the person donated a little bit ahead, but not years ahead. And so this was the first time where we came up with this concept of a voucher or, a promissory note. And at this point in time, it's really not like it's a guarantee. Because we can't tell you for sure if this nonprofit is not going to fold in 4 or 5 years from now, because we're dependent on a lot of other people to keep this system going. But what I can tell you is the energy and the innovations are here and alive, and a lot of people want to make things happen so that we can, get more and more of patients not needing to be on dialysis so that they can have a good quality of life. So this young boy, if he ever does get to the point where he needs a kidney transplant, will likely be able to get a kidney transplant well before he needs dialysis and before he starts to develop chronic changes from kidney failure. And I'll let our nephrologist talk about some of those. But this is kind of where we see the future of our efforts, is having people, as they get older, considering to donate. And the other thing that may play into this is the people that are more likely to need kidneys are older people. And so, we could give his kidney to an older patient, and then their younger donor may be able to give to a younger patient. So there may be a win-win in this whole scenario.
So we'll talk about transplant outside the U.S. And this is for
So-
U.S. citizens.
The question is, why would you want to do that? Right? Well, mainly because the rules are maybe not so tight outside of the United States, and people may be willing to do things that we're uncomfortable with. And this is where there's a little bit of a slippery slope. Number one is not all countries have the same legal requirements for being a hospital, for being a physician, for safety standards and other things. They may not have the same rules about the separation between the donor evaluation and the transplant programs. And to some extent, it is in the United States illegal to give up your kidney for what's called valuable consideration. Now, that was kind of a vague definition, but the bottom line is you can't get paid for giving your kidney. But that's not necessarily the case in all parts of the world. So in some places, you can get a kidney transplant much sooner than you could in the United States from a deceased donor. But there have been a number of atrocities that have been identified linked with these kinds of programs. And so the World Health Organization and the International Transplant Society has basically tried to shut down these illegal activities. Some of them are actually legal, though. Until recently in China, executed prisoners were eligible to donate kidneys. In Pakistan and in the Philippines and in Iran, there were legal situations where it was possible to donate a kidney for valuable consideration legally. But many of these, quote, loopholes have now been closed, and even in China, they realized that this is not actually the best solution to their own internal national needs and for the benefits of their societies. So Dr. Danovich is our medical director. He's been a very vocal person who has been against these practices. But we understand that some people would consider this as a last-ditch effort, but we just wanted you to realize that there are risks to doing so, not only financially, not only medically, but ethically. So we just wanted to leave you with that.
So there's a question over here, and I think I'll put that for Dr. Kamgar. Does a donor's prior cancer preclude donation?
Most of the time, yes, but it also depends on the type of cancer and the time from the time that that's considering to be a donor after the cancer presentation. So some cancer, like breast cancer, basically disqualify from being a donor.
Yeah, and also as simple as a skin cancer, right? If you have a melanoma, they are probably excluded for life. Not probably, they are, at least in our program. Yeah. But if they have basal cell carcinoma, so it depends from cancer to cancer. But it's in majority of cases, there is a pretty good likelihood that they might be declined, but they should contact the transplant program and see what's best. Because it's not just for the donor, it's also for the recipient as well, because of cancer.
And also the stage of the cancer and type of the cancer.
Yeah, if it's early versus late.
Yeah, I think the key take-home message there is don't make an assumption. Call us. We
Yes.
will evaluate the situation and look into it in detail. For instance, some cancers like prostate cancer are very common, but actually very unlikely to spread. So depending on if someone was treated for prostate cancer, and let's say 4 or 5 years have gone by and there's no evidence of any spread of that tumor, then that person is A, likely cured of it, and B, very unlikely to have a risk of transmitting it to somebody else. So this is changing a little bit as we really look in great detail in terms of the kind of cancer and the risk of spreading in the future.
Very good. Great. Is that
Well, I think this is nearly the last slide. There are a few people, because of the timing, that really need to have a living donor. So patients in Los Angeles that have blood type O or B at our center are waiting nearly 10 years before they'll get a deceased donor kidney. So if they're over age 65 at this point, then it's not likely that they're going to be a good candidate for a kidney transplant 10 years from now. So we don't generally put them through a whole big evaluation process. So these are the people that really need to have a living donor to be able to have the benefit of a transplant. Those patients that have a lot of antibodies and have not been on dialysis for a long time fall into a similar situation where it's very, very difficult to find a kidney for them. And so the desensitization becomes very complex if we're waiting for a deceased donor. If they have a living donor, then we really know how strong is that reaction and whether or not it's something that we can treat. If the patient that needs the kidney has a very complex medical situation, they may have hardening of their arteries or they may not have a bladder, oftentimes it's much better if you have a living donor because we can organize a whole team of people to help with that special reconstruction. And those that, again, have a very high risk of rejection, a living donor certainly gives us a much better option. There's, I should say, one other group of people that should not have a living donor, and those are those that have a very high risk of their disease recurring in the transplant. So there we're somewhat reluctant to put a healthy living donor kidney into someone where the chances that kidney survive is relatively low, but we still want to give them a chance.
very good? So who pays for the transplantation? I can have one on my panel.
So basically the recipient's insurance mainly pays for it. It's not as
Just
strong.
soft-spoken like me.
Yeah, it's usually the insurance of the recipients pays for transplant.
And there is, we discussed that. So it's at no cost to the donor. The donor won't have to pay, but they are indirect costs that the donor does incur.
Yeah, there is there's sort of a national understanding that there are some costs to being a donor that are not compensated, and there are increasing efforts to remove the disincentives to kidney donation. So for those that are financially meet certain qualifications, there are national funds available to cover some of these costs, whether they're travel costs, parking fees, and other things that may not be covered by the insurance. In addition to that, the costs of the operation and all of the care for roughly 90 days after a donation are easily covered by the recipient insurance. But when we start getting further and further away from the recipient operation, it becomes harder and harder to send those costs to the insurance company of the recipient. So it's one of the reasons why we do want patients to have some access to health care before we recommend that they donate a kidney. And then finally, I think as an institution and personally, we are trying to build more philanthropic support for some kind of a safety net. because we realize that people that donate kidneys may not all have a crystal ball either, and they may not always know what's coming. And so, if someone donates a kidney, ultimately it would be nice to have some kind of a safety net that's built there for them. And I think we have room for improvement in that regard.
Very good. So this is a question that we get asked sometimes. They have donors outside the U.S. and then once again contact a transplant program, and we'll try to help them get into the U.S. for the evaluation.
Again, we want to make sure they have some access to health care, but it is possible for them to come and donate.
And these are some of the links. And we'll send this via email as well, so you can go and visit. And then we have some of our coordinators at the bottom as well. Okay, so with that, I think I just want a round of applause. Dr. Gritch, thank you very much. Dr. Kamgar, Dr. Cohen, Dr. Novak, thank you so much for taking time on a weekend. And are you guys still going to be